Yeah.
Good morning, everyone. I hope that those of you who are local remotely can hear well. We are using this auditorium, as you know, because we have the Joint Commission visiting the hospital, and the main auditorium in cardiology are occupied today. Today, obviously, we have an incredible opportunity and a great pleasure to have Dr. Valentin Fuster, who really requires no introduction. He's someone who is probably the most recognized figure in cardiovascular medicine in the world. He's an incredible human being, a mentor, and someone who really have taken cardiovascular medicine to another dimension. Dr. Fuster is now the president of Mount Sinai Fuster Heart Hospital and the physician-in-chief for the Mount Sinai Hospital in New York. He's also the director of the National Center for Cardiovascular Research, or CENIC, which is equivalent to the NHLBI in Spain. He had served multiple roles, first starting his career from after he finished training at the University of Barcelona, both at the Mayo Clinic and Mount Sinai. I got to meet him and work with him as a fellow when he was a chief of cardiology at the Massachusetts General Hospital, a little bit after you, following in your steps. At the time, I remember attending one of his lectures, and he really was defining a new paradigm, which was the way that atherosclerosis was actually evolving, and the concept of a ruptured plaque was completely changing the thought that we all had about the evolution of atherosclerosis. I moved to Cleveland, and he got me back to work with him at Mount Sinai. About 12 years later, I had an amazing opportunity of meeting some of the most remarkable people in the world from different areas, government, science, art, and all these people had in common a profound admiration for Dr. Fuster. I was very privileged to watch him, and I think as a mentor, what was most important for me was able to observe how he was conducting himself on a day-to-day basis. And as I'm getting older, I have problem with my memory. So I have a few things that I have forgot, but there's one that I will always remember. And it was one opportunity when he invited my family and I for dinner at his house. And my late parents were having dinner, and Dr. Fuster was serving the food in their plates. That remarkable example of servitude and humility is probably the greatest characteristic that any great human being has. So thank you so much for being here, Valentin. It's a great pleasure.
Thank you very much. Thank you, Mario, for your kind words. And it's nice to be here today. I was supposed to talk to the fellows, but was mixed up. I will have maybe some other opportunity to get together for a while. Yes, I'm going to be talking about new frontiers in cardiovascular health, and you might be perhaps surprised when there is 224, 234. What I'm going to do is to address what I think is going to happen in the next 10 years, and is already happening. So it's not going to be like a dream, it's a reality. Now, we're addressing a paradox, which I will try to verbalize this morning. And that is, on one hand, we have a tremendous development in technologies at all levels, but there's a tremendous deficiency in public education. And this is a complete disparity that I think I like to reflect into what is next. Now, let me start with technologies. Here on the right side are the technologies I'm going to be talking today: imaging and genomics, cell biology, new therapies based on RNA, gene editing, and so forth, in artificial intelligence. These are technologies that are evolving today very, very rapidly. To give an example of all of them, you know, today we can address with any technology molecules and tremendous number of variables in our body, like can be fat, can be infrastructure, the ultrastructure with magnetic resonance imaging. This is cell biology. With PET, we can develop these technologies to see the activation of the bone marrow with the monocytes getting into the blood to defend us. In terms of therapies, you know, what is evolving is fascinating, and that is, for example, the neutralization of the RNAs. You know, for example, with inclisiran, which is a drug given subcutaneously twice a year for lipid lowering, and just neutralizing the RNA that PCSK9 is actually blocked. The new antihypertensive medications, which actually prevent the development of angiotensin, 2 injections a year may be necessary to treat hypertension. That's one hand. And on the other hand, these RNAs can be defense mechanisms to us. Examples, the vaccinations that we have with is basically enhancement of RNA. If you look at the drugs in heart failure, it's an enhancement of the defense mechanisms that are available today. So it's a fantastic what is happening with the new therapies that are evolving, going very much into the synthesis of molecules that are critical in health and perhaps in disease. And in terms of genes by themselves, you know, gene editing, like what happened recently with amyloid and so forth. So this is the new therapies are very exciting in terms because they really go to the very, very origin of molecules that are critical with the RNA editing and so forth. And then we can go to artificial intelligence, and you know, it's an example how many times we see patients with multivessel disease, and you look at all the variables to make a decision of surgical versus PCI. Well, Dr. Patrick Serrois comes up and says, well, we can do this with artificial intelligence with all the different points and variables being together. Well, what I'm really showing to you is a development of technologies that are going to be in front of us, and they're already beginning. But here's the question, when we go back to history, it's very fascinating to see what happened with cardiovascular mortality. It's fantastic, isn't it? Females and males decrease in cardiovascular mortality from the year 2000 to 2010, 2012. Development of intensive care units, defibrillators, cardiac surgery, and so forth really made this difference. Maybe the use of drugs like statins contributed to. And here is where a few years ago, I still remember people talking, the cardiologists are fantastic. There is a miracle what is happening in cardiology. Well, the reality is that I developed a crisis on all of these when I was involved with a number of organizations, and I saw that. And that is, we have been fantastic, but something is going on here. 2010, 2015, the mortality has reached a plateau, and in this country, mortality is actually increasing today due to cardiovascular disease. I have more to say. So it's spectacular what we have done in a couple of decades. But if we continue to talk about the spectacular, is in front of us, something is happening, which is pretty bad. And that's basically part of the discussion I'm going to have today. So with this in mind, I made a decision, is like an existential crisis. I work, as Mario mentioned, a lot on the plaque rupture and all what happens in the vessel wall leading to acute coronary syndromes. But at that time, 10 years ago, I decided to change completely my way of addressing research, and I went into health. That is, can we understand health? It seemed to me at that time that we knew more about disease in coronary syndromes and so forth, and actually what makes health. What are the mechanisms that defend us to be healthy? So I moved from the bottom to the top. And then the question is, if you're going to address this, you have to use the most recent technology. So what I'm going to be presenting to you today is new technology addressing health, not disease. And that's my talk. And the question was, to address health is quite different, as you will see in a moment, if you deal from birth to age 20, here in the bottom, from age 20 to 60, or from age 60 to 100, you will see in a moment what I mean. If you are asking me, what is the challenge between age 20 and 60 in the cardiovascular field? To me, is are we developing arterial disease or we don't? And what we do is risk factors and so forth, and we try to predict, but that's not enough. Can we see the disease directly? And this is really how we took off 10 years ago, is developing imaging technology that can see the arteries externally, because the disease is systemic. So if you see disease in the carotid arteries, or in the iliofemoral region, or in the aorta, you can predict the coronary system will be affected. The disease is systemic. Well, let me then focus into what we have done with these between age 20 to 16. There are 4 findings that I will be presenting with the 2 trials that are just starting this month for the next 10 years, based into the 4 findings that I'm going to be presenting to you. Well, we started actually the PESA studies in Madrid. This is for 4,200 people, 1,500 women, in which we are following for 20 years, every 3 years. And we have 2 objectives. One is new modalities of imaging, and the risk factor profile, which by artificial intelligence, we look at more than 4,000 parameters. And I will be talking about the findings here, 4 findings, and then we move into genomics, the relationship between imaging and genetics in arterial disease. Well, let's begin with the 4 findings. This is finding number 1. These are males, the people in the PESA study is 40 to 55 years of age. 4,000 people, apparently normal. These colors that you see here, these more than half of men at age 40 have already disease, either in both carotid arteries, one or the other, iliofemoral region, aorta. We use calcification indirectly for coronary disease. Half of them, more than half. In women, is about 1/3 at age 40 have already disease in the systemic arteries. In a matter of fact, the disease begins at age 20, and in 75% begins in the legs, interestingly. The thing is not manifested because the arteries in the legs are large. The coronary arteries are small. So when we have coronary disease, I can tell you there is disease already by ultrasound in the iliofemoral region. So this is very important because it's telling us the disease is there. So probably is the most important risk factor. But even so comes number 2. And this paper got the award of the year by Jack, which is what we decided to do, as I mentioned, every 3 years to follow these people. And what we found is that the disease progresses in 33% at 6 years of follow-up, and regression in 8%. So this is a reality, but there is something else that was quite interesting, is the risk factor profile. What we found is that risk factor at younger age has much more impact on the reactivity of the arterial system than in older age. Let's say an LDL of 160 at age 40. The impact that we found in disease development and progression is much more significant than the same level at age 60 or 70. So what I'm really saying to you is that we don't pay attention what happens at young age, but the impact is much more significant with a given risk factor. And this was the paper that was awarded. Hypertension, we found the same thing. Cigarette smoking, we found the same thing. So a risk factor profile in the first 40 years of life is quite significant into the impact. So this is number 1 finding, and number 2 in terms of progression. Here it shows what I said about the risk factors. I don't have to repeat it. Number 3, and this is quite interesting. If you go to guidelines, an LDL cholesterol of about 80 to 100, 110 is normal if you didn't have any cardiovascular event. But look, if you look at disease that is subclinical, significant, so a normal level without subclinical disease should be an LDL less than 70 or 60. So there is no individual that I see today, normal or abnormal, that I don't go for an LDL less than 70 or 60. And this is about subclinical disease. What we are finding is the impact of subclinical disease. But look at diabetes. This actually will be published next week. And it's fascinating. Here you have pre-diabetes. Pre-diabetes, you know, with a hemoglobin A1C of 5.7 to 6.5, you say this is an alarm from diabetes, but maybe an alarm for some people. There's a lot of subclinical disease. But what is most fascinating is actually here. This is insulin resistance. So before pre-diabetes, there is insulin resistance that we measure in the 4,000 people, and already a significant subclinical disease. So we are so late in our thinking. First, we dismiss the young people, and second, we dismiss subclinical disease when we go into guidelines. So completely primitive. This is why I'm talking to you into what is happening in the next 10 years, because if we go back to what is happening, we are completely behind in the field. So this is actually the third aspect. And the fourth is critical. You remember, many of you, the Cardia study. We got into the Cardia study, 2,000 people between age 20 and 40. Between age 20 and 40 is in the abscissa. Look in the ordinate, is LDL, fluctuates. So we measure the area of the LDL, the area of blood pressure, the area of triglycerides, and predicting 30, 40 years later what happened. And this was just published. Look what happened. Larger is the area, LDL in red, at baseline, higher is the cardiovascular events and mortality, triglycerides, blood pressure, everything. So what I'm really saying is progression of disease is not something that is subclinical, it's the impact that have later in life. So young age is critical because the impact of risk factors is much higher than later in life, but at the same time on the vascular reactivity, but at the same time you see the events. Well, very interesting. Many times we say this is the level of LDL and then we make all the predictions. Well, let me give you an example that is fascinating. Here you have an individual that has familial hypercholesterolemia. And here's an individual who does not have familial hypercholesterolemia. At age 60, both have the same level. But the results are going to be different in outcomes, completely different. You know why? Because the LDL here has been elevated from very young age. The impact of time of a risk factor is very significant. We don't pay much attention. You at age 40, you say Framingham is predicting what happened before. And what we are finding is what happened before is much more significant. The timing that the risk factor has been present. And I present this example just to say to you how important is not just the level, is for how long the level has been present, and particularly at young age. That's really what I'm talking about. Well, this led to the study we are starting next month, which is the pre-CAT study. 2,000 individuals between age 20 and 50, we consider abnormal if they have an LDL more than 70. And then these individuals, we are going to be following by two groups. One is usual treatment, and the other is progression of disease with the use of inclisiran. That is 2 injections a year. And you say, why you don't use the usual? Adherence in young age is very difficult. So if you get into a trial of a 30-year-old and you try to say, take statins every day, my prediction to you, and we already have the data, it's not good. It's not going to happen. So we have to go for adherence here, which is one of the main problems in medicine today. This is why we use subcutaneous inclisiran twice a year. And that is, you don't have to really go into the adherence problem. This is the study. And it's based on everything I mentioned to you. So we go between age 20 and age 50, and we consider abnormal an LDL more than 70. And then we have the progression of disease and so forth. This is the first study. Well, I presented to you 4 findings with the study that is going to evolve in the next 10 years, which is the pre-CAT study. But I said, here we also measure genetics. I could spend some time on something that is fascinating. I don't have much time here today, but I will tell you just a grasp of what is happening with the genetics in cardiovascular arterial disease. I think this slide is actually critical, and that is when we have, for example, cholesterol in the arterial wall, the bone marrow reacts with the monocytes. And the monocytes, what they do, they go to where the cholesterol is and they take it out. And then the plaque that is active with positive emission tomography, I'm going to show you, becomes fibrotic with MRI and calcified. Calcification is healing. Okay, now I'm going to show you this. But here's where the genetics begin to evolve, is by looking at cell biology. So first, what happens with the bone marrow when there is cholesterol deposited in the artery? Well, the story is the following. We did 900 individuals of the PESA study, positive emission tomography, and we were able to see activity of the bone marrow. That's number one. And then at the same time, we could see this material in the arterial wall, which is basically the interaction of the monocytes from the bone marrow and the cholesterol. It's like a war. Who is the winner? The monocytes from the bone marrow or the substrate that is in the artery? This is number one. And again, in the bottom, I have the recent publications in all of this. Well, this is actually very fascinating because this is the story. Here you have active disease in the iliofemoral region, aorta, or carotid arteries, positive emission tomography, activity. And he is healing with MRI, fibrotic phenomena. And actually what is happening is that if the monocytes are the winner of this war, the whole process is compensated and the result is a fibrotic lesion and is over. You know, the fatty streaks in autopsy, this is what I'm talking about. It may end up with a fibrotic phenomenon in a plaque in the arterial system. But what happens if the risk factor profile continues to make cholesterol to enter into the arteries? The war is lost. The monocyte commits suicide. All of this we have published. It's apoptotic phenomenon that we call. Here you have a monocyte comes in, gets apoptotic, but this suicide is not just a suicide. It begins to release substances that are very toxic, tissue factors and metalloproteinases. So today our concept of an acute coronary syndrome is a decompensation of a defense mechanism that is failing. Metalloproteinases cause blood rupture, and the tissue factor causes the blood clot. I think this is very important because all of this comes from studying health and defense mechanisms. It's a completely new way to address disease, is by understanding what happens in health. Well, this is apoptotic, but there is something else that is the so-called chip in epigenetics. This is the second aspect. Chip is when the cells from the bone marrow are mutated and they are not doing the job. You know in how many adults? 25 to 30%. We have the data. It's going to be published actually next week in Nature Medicine. And that is, you have an individual who develops an acute syndrome. There are no risk factors. Well, you miss one, a very important one. The defense mechanism is failing, is mutated. And this is called CHIP, mutation of the hematopoietic cells from the bone marrow. And that's our explanation why the disease may develop without any risk factors that are in front of you. This is number two. Well, I presented the data. I don't have, this is the data. You see, it starts with mutations of the bone marrow cells, and this ends up with disease. We have all this by mapping. Number three, epigenetics. You know what epigenetics is. Starting with the pregnant women who were smokers and something was wrong with the babies. And then the question is, basically, the epigenetics means that the DNA methylation of the DNA. And then what happens, to be long story short, is the syndrome of obesity, the metabolic syndrome that is here with obesity, hypertension, and so forth, and low HDL actually affects the bone marrow. This is PET. the activation of the monocytes in the bone marrow by the risk factors. So the risk factors not only affect the artery, and you know what is happening? Methylation of DNA. So the cells that come from the bone marrow are much more active. So what I'm really saying is now the risk factor profile that we think affects the artery in cholesterol enters, it affects also the bone marrow. And the cells that come out are much more active, and this may create disease. So what I'm really trying to summarize for you with epigenetics is the risk factors get into the bone marrow in the process of inflammation or monocytes are very active. So I'd just like to summarize by going back to here. Very fascinating, the role of the bone marrow in arterial disease. I still remember I started with platelets when I was a fellow. Nobody believed anything about platelets in disease. In fact, the meetings I went were the hematology meetings, were the only people who listened. It's going to happen with the bone marrow. I can predict for you that all of you will be talking about the bone marrow in the next few years, because it's absolutely critical in the disease that we are talking about, because it's a defense mechanism. It's there. COVID, for example. You have a virus, is a strange substance. Monocytes come from the bone marrow. You know, the syndrome, the thrombogenicity, the syndrome of lung disease and so forth is the apoptotic phenomenon of the monocytes in the blood. And the patient that gets to go into the units to have mechanical support. It's the same thing. It's always a fight between a defense mechanism and a substance that is strange. And the question is, who is the winner? And in COVID, if you end up in an intensive unit with mechanical support, the monocyte is apoptotic, is releasing all the tissue factors, the prothrombotic and all of that. So it's the same happening with cholesterol in the artery. Well, I just wanted to say this compensation, there is apoptosis, then there is a risk factor that is cheap, the defense mechanism is not working, and then there is a hyper-inflammatory response with risk factors in the bone marrow, and epigenetics with the metabolic syndrome is an example. So all of these, the imaging and the genetics led to the study starting also next month, which is the REACT study. The REACT study is the study of 16,000 people in a number of countries in Europe that we are going to lead with all what I presented to you. The imaging that we did already 4,000 individuals in PESA, and all the genetic studies that I am presenting to see how can we change our approach in the future by working from healthy individuals. These individuals will be young too, starting much earlier in trying to move forward. So this is what I wanted to present to you in talking about this problem, age 20 to 60. What is the future? It's beginning. We are going to developing countries now. And you know what we do there? With we have standardized already the 3D ultrasound. It will be available for the public next year. We go into the iliofemoral region. We look at this disease or not. And then we look at the risk factor profile without drawing blood. In these countries, you don't have the opportunity to draw blood and all of that. And we say, well, if the patient is obese and so forth, this might take care of the cholesterol and so forth. But you get a sense by seeing the disease and without drawing blood in less than 45 minutes, what really the problem is and the prediction. And now, I don't go any further, I don't talk today, but we're going to use a polypill. I want to get into the polypill story here, but it's the way that is moving, all of these coming from health and moving into try to prevent disease in the most economic and the most simple way. And this is how this is evolving. Well, now comes the second part of my presentation, which is fascinating. What about age 60 to 100? If you really look yourself, what is the question? I suspect you are in agreement with me, is senile disease, cognitive dysfunction, Alzheimer's. That's what it is. So the question is, what happens if you use all these new technologies as we are using, but addressing the brain? Technologies that were not available until very recently. And this is what I like to present now. the work that I'm presenting is many of us involved, for example, in the brain, which is interesting. I'm spending 50% of my research today is in the brain, which is, as a cardiovascular guy getting into the brain, but that's what is happening. And this is the group that we are working on this. And actually, it's very fascinating what actually the findings are. Let me go back to Alzheimer. Alzheimer, more than 100 years ago, said, my disease is a disease of the arteries. It's not fascinating? This was a pathologist. And what he was saying is, Alzheimer's disease is a disease of the arterial system. The question that I'm asking is, why 100 years have all been devoted to the neuron, but not to the arteries? Well, first, there was no technology for the arteries. This may be an explanation. And the neurons, you can always look at function and all of that cognitive. Well, the reality is that we are now convinced that Alzheimer's disease is a complex disease. I have more to say in a moment of the neurons, but the arterial problem makes the disease to progress. And now I'm going to get also into the senile dementia. Let me tell you how this all started. This actually started in 2018. We did a transatlantic study with all the new technology I mentioned to you between New York and Madrid. And at that time, the hypothesis was the following. Large vessel disease, iliofemoral, carotids, aorta, or risk factors, they may affect the microvascular disease of the brain. Why we said that? Because the pathologists saw that hypertensive people that are not being treated, there was intimal thickening of the microvasculature of the brain. The same with diabetes, and the same with hypercholesterolemia. It's not atherosclerotic disease. It's disease of the tiny arteries with intimal hyperplasia. That's what the pathologist said. So what we decided to do is to do MRI and to measure flow in the brain in people in the PESA study that I mentioned, and in New York, people who had significant risk factors, hypertension being untreated and so forth. And we saw a decrease in the flow in the brain. We saw, this is published, a decrease in the uptake of glucose in the brain, which we thought was related to the decreased flow. And finally, we are looking at this now, putting the data together, is cognitive function being affected? This has actually evolved between 2018 and 2021, but there was one problem. This was not every individual had the same testing. For example, Mario, I can do a new MRI of the brain with flow, but then I go to you and I do PET. You both have risk factors, but it's not the same individual. This led to two studies that we started very recently, and this is the so-called heart-brain axis. This is our 1,000 people that we follow all the technologies in these people. Everything, flow with MRI, PET, cognitive function with MOCA, everything is being done. Number one. And number two, very interesting, biomarkers. You know, all of us in cardiology are used to use troponins to assess if the myocardium is affected. Well, very fascinating. We now can look at the brain with very minor injury. You can see NFL, GFAF, etc. And also tau in some of the proteins, ApoB, that are actually in the brain of patients with Alzheimer's. So these are the two projects we are following. Well, we are just having data. We just published this in The Lancet just a few weeks ago, the beginning of this study, and it's fascinating. These are people, 370 people, that actually had hypertension, diabetes, or hypercholesterolemia, two of them. And then what we did everything I'm talking about. But the most striking thing was the uptake of glucose in the brain. This is a baseline, and this is after 6 years. And we have a lot of data on biomarkers. I don't want to bother you with all of these, but certainly getting a feeling that when I talk about disease at young age, risk factors at young age, eventually the brain is involved. And this is another issue for which education is critical at a very young age. is because we are not paying attention that this is nothing that happened later in life. It's cooking during very early stages of life. The same that the large artery disease, the microvascular disease of the brain, is being affected. Well, let's do the second project is about biomarkers. There is a paper in actually in the New England Journal 2 weeks ago. It says Alzheimer's disease, we might predict if we look at the spinal fluid and we detect tau or we detect amyloid beta. What about what you read in the New York Times today with ApoA? Just read the New York Times, it's in the first page today. Well, this is the story. We just published this actually next week, which is very fascinating. One of the biomarkers that we measured was ApoA, apolipoprotein E, in this case. And let me go into the details, just concentrate here. This is Framingham, high risk, moderate risk, and low risk. Interesting, this in color means Framingham works. This is subclinical disease. In Framingham, do you look at events you predict? But this is the subclinical disease that is present in high risk, moderate risk, and low risk. And this was in the PESA study. What is fascinating is the relationship here is EPO, the ApoE4, significantly related to arterial disease. And what is now found in Alzheimer's is because disease, the same molecule, is affected the arteries of the brain and eventually causes Alzheimer's. This is my interpretation of the data published yesterday in Nature Medicine. What is interesting is ApoE2, you see that? ApoE2 is actually a defense mechanism. So the question is, can we enhance ApoE2 compared to 4? And then we might be able to succeed in the future with medications. Well, what I'm really presenting to you is that we are in the moment of a breakthrough on brain disease. And that is the same risk factors that are affecting the arteries with atherosclerotic disease, like here you have DEPO, is also affecting the brain. And this can take many years into the brain being actually exposed in terms of symptomatology. Well, everything that I presented to you is technologies that are evolving. We have 2 studies on a young age, as I mentioned, the REACT study and the PRECAT study. We have 2 studies on the brain, which is the ones I presented a minute ago into the brain study or the imaging in the brain study with biomarkers. All of this is evolving. Now, the question is the following. To study health is excellent, and I presented to you what we have done, but still, with all the new technologies, we're having a problem. And here I want to verbalize the problem, because this is actually, we have a consortia between NIH, JAC, which I was the editor, and then the system of disease, of prevailing and preventing disease in Seattle. And what we look is 1990 in colors, 2010, 2020. Do you know what it is? Obesity. So everything I presented is fine, but now let's go into the real world. Obesity is increasing. Second, even worse, obesity is increasing in the adults, but this is in children. And what is interesting, that 75% of the obesity in adults starts in childhood. So what this means that maybe working on health is fine, but if we don't go to young people, even just looking at the slides, we are not moving forward. I already presented the importance of young people, but now I'm presenting even more. Well, and this is the prediction in 2060. It was just published about a year ago. The prediction of obesity and the prediction of LDL cholesterol is going to increase. So we are really in a situation that we are all excited by new technologies, but we have in front of us a huge problem, and that is the world of consumption is beating everything that we are doing. in terms of prevention. So this led us to moving from health into childhood. For everything I presented already, I think it's the time to begin to do something. And here's the story. I don't name the people, but I always put the people who actually led the studies in all of this. Now, about 10 years ago, I was working in children, and Sesame, is an educational program that saw me on children, says a doctor working with children may be interesting. So they recruited me. And Sesame Street, this was an educational program on television. I still remember my children watching this every Saturday. And these were actually for children between age 3 and age 6, basically what Sesame was. Well, they recruited me. The first thing we did is to change Cookie Monster. Cookie Monster used to eat cookies 7 days a week, and we made it 1 day a week. Well, this is probably my most important contribution in medicine, Mario, is the Cookie Monster. What happened is this had a huge impact on children because they began to ask why. And that's what we got into health, in telling them the importance of health, the priority of health, and so forth. So today's Sesame is only on health. Is not on anything else. Malaria, TB, HIV, Chagas is in all over the world teaching health. That's what the Sesame went. Well, but something else happened at that time, and that is data were evolving that at young age, the number of centers in the brain is relatively small and less dense as compared with later on in life. So whatever you tell a child, anything is a store, it's easy. In an adult, it's much more complicated. There are too many centers and too many messages and so forth. And the concept that evolved, which is interesting, is that our behavior as adults have a lot to do with our environment in the first 10 years of life. And actually, if you look at yourself, you will see how right I am. And that is lots of the way you are, that environment really play a very important role. And probably is related to the concept I am presenting to you. So we took this concept and we said, let's now begin the projects. Go to children and try to instruct children in a way that is intensive, that health is a priority in their lives. And interestingly, we tried New York, the Board of Education, and they said, no, this is not of our interest. Actually, it was interesting. I still remember. I couldn't believe how bad it was, the response to what I wanted to do. And actually, I worked with President Clinton when I was president of the American Heart Association. And he said, you will never make it in this country. I still remember, you should go to Central America because they are more organized and they are more passionate. Fine. So we went in Bogota. The Bogota went to Madrid, and the results were so successful that we ended up in New York again. But we started in Harlem. Let me tell you what we found. 4,500 children altogether in 3 different socioeconomic locations. Half of them were treated in the following way. 6 months, actually 60 hours of how the body works. This is very important for children when you talk about weight and food habits, physical activity, and how to control the emotions. So making self-esteem, that when later in life they are confronted with drugs, alcohol, and so forth, they are able to say no. Very important to be intense on this, on the self-esteem of these children. And the other serve as controls. We have published all of these, but let me now summarize the data. And there are good and bad news with the data we obtained in these 4,500. And this is research, by the way. First, a surprise. This is a conglomerate of studies, and I don't want to go into the details, but basically you instruct these children, everything works well and works well, but 2, 3, 4 years later, they lose part of what you told them, which is against the concept I just presented to you. The question is, maybe we have to reintervene sustainability. The second was very good news. Look the control group. If you are in an environment that you talk about health, look the control group, how it works. Amazing. So this led us to develop two huge projects that are beginning and are quite fascinating, and actually is next for the next 10 years. The first is called Sustainability Project. It's in New York and in Madrid. And basically what you do is you repeat the instructions to the children. And we're actually working between age 3 and age 20. Let me give you an example of what we do. You can instruct a child at age 5. And then you instruct again at age 10. Compare with another that you only instruct at age 5 or at age 10, only once. The results are quite different, are exponential when you intervene. And actually, we found this in adults too. We have lots of projects in adults. We as adults, whether you talk about health or anything else, at the moment that you do fantastic, I can tell you, it's the beginning of going down unless you reintervene and you do the same thing. So this is a general principle in life. The sustainability leads to intervention on anything. We found this in health in the children. So this is the problem, the question of sustainability. But then the other study has to do with the environment. And this is fantastic. And actually, this is the most successful study we had in children. What happened is we went to the family. The environment is now family, parents, children, and grandchildren. And it's all through Muppets of Sesame. And one, is the doctors, Dr. Rooster. And we have 24 films. And what we do, the same 4 aspects I presented to you before that we did on children, Bogota, Madrid, and Harlem. Now we go to the families in corporations, workers in corporations. We did 2,000 people, absolutely a success. And it's a year project. You have the 4 things, it's for a period of 3 months. You repeat with more maturity. Adults have the 4 aspects different and more mature than in children. And the results are fantastic, and it's working in the environment. So my conclusion is we can do anything you want on children and in the school system, but unless you work on an environment, the results will not be as good. So sustainability is critical, and the environment is perhaps more critical. And that's basically what we are learning. And then we have an international study on environment. So 224 to 234, this is all in childhood and families. Actually, we're going to work in the Bronx here, in New York, in District 9 and 10 are the most poor, and in Harlem. And then to the whole United States, and then in Latin America. This is all the project that is going to be so primordial prevention. Well, I just finished by saying to you that this is what we have learned. Is first of all, in working with health, from age 20 to 60, is critical imaging of the large arterial and risk factors. And there's a lot to be gained. And then the genetics I mentioned to you. Age 60 to 100 is the brain. Things are advancing tremendously, but everything begins very early. And the question is education, which is between age 3 to 20. So in fact, the paradox I mentioned at the beginning is a real one. That is, science is advancing very rapidly, but we are missing the opportunity to do something in terms of education. That's the real issue. We can be all investigators and enjoying what we found and define this and what happened last night. But the reality is we are in a world of consumption, and the question is how you beat it. And education is critical. So earlier you start, higher is the benefit in terms of the results, and lower is the cost. Where what we see, all of us see patients, and we are obliged to see the patients. The cost is very high, and I'm not entirely sure the benefit is so significant. So I finish by saying to you that we have a paradox, and I wanted to address you. At least all of our projects are two in each in different age on the next 10 years. And these projects are not more of a manifestation of what you are going to begin to see is a movement towards health, a movement towards young people. We'll see guidelines. All we will do at age 40 with Framingham will be at age 20, I can predict. We will have very simple imaging technologies. They will see you have disease or not. This is the highest risk factor by far. and in addition to the risk factors. And we need a lot of education. And I just wanted to emphasize, when we are in the educational tool, I think the environment is so critical. I'm beginning to see, we can do everything individually as we do in the school system and so forth, and to look at sustainability. But, the most important is the environment. If we can create a culture, and this is what we are trying to do, first, starting here in this area, and in the Harlem, and also in Manhattan, and then we go into the whole of United States. This is a step 2, and then Latin America, step 3. What we try to do is to create a culture. That, to me, is the bottom line of education. And I think with this culture, I think we might begin to win this war. That is, technologies should continue to advance, but maybe education may be ahead of what it is at the present time. Well, I finished by saying thank you very much. I know I was supposed to meet with the fellows. I cannot do both because I have to go to the hospital now. But the fellows, I promise, if you want to meet, I will find the time to meet one of these days and to have maybe 1 hour of chat. Maybe it will be easier for me to do it by Zoom if you don't mind, but I will be happy to do it. Okay? Thank you very much.